it was about 50 people, so I will wait a little bit more because I see
The
they are
count goes up.
joining. Yeah, it's counting upwards. So
Yes, people
Boom.
are still connecting, so we can allow it another minute.
yeah.
So we wait until it reaches 1,000, I would say, and then hello.
Hello. It's counting upwards. Okay, let's go. So hi everyone and welcome to today's webinar on traumatic brain injury prevention that is organized by the EANS Neurotrauma section. And my name is Elham Rostami and I'm really delighted to moderate this session, and thank you all for joining us. And we are really fortunate to have two great speakers with us that are part of the Neurotrauma section within EANS. And our first speaker is Professor Bart Depreitere from Belgium, and he will speak on brain injury mechanics, head protection, and TBI prevention. And we will see how we can understand injury mechanisms and how prevention strategies can be optimized. And it will be followed by Dr. Alexander Younsi from Germany, who will present TBI prevention in the aging population, challenges and opportunities. And he will address a rapidly growing and often overlooked area within TBI prevention. So I hope you will enjoy these talks, and then we will have time for discussion and your questions that you can put in the Q&A chat box. So with that, I would like to welcome Professor Depreitere to start his talk. Please.
Thank you, Elham. And I'm sharing my screen, and I hope this works. Can you see my screen now?
Yep. Yes, we see also your, it's not like a whole screen.
No.
We see also the next slide. It depends on if you have no, perfect.
Perfect. Okay, perfect. Thank you. So I'm really happy. Thanks for the invitation that we can discuss TBI prevention. And I think that doctors in general, but neurosurgeons in particular, should be more aware about TBI prevention. I think it's the most powerful tool we have for our potential patients and to prevent that they become patients, obviously. It was also the topic of my personal PhD thesis, and so that's why I'm very happy to talk about this. So these are my disclosures. And this is an outline of what I will try to cover today. So why prevention? And then the main topic will be on understanding brain injury mechanics and on how to prevent. And finally, surprisingly, there's also a little bit of resistance against this and some political maneuvers, but I will explain what I mean by that. So first of all, why should we try to prevent brain injury? Well, we know that brain injury comes with a burden of mortality in moderate and severe TBI by 10-15%. And also morbidity and the rates of unfavorable Glasgow outcome scores in most studies are as high as 20-25% without mortality. So if you add mortality to that, it can quickly become something about 30 and 40%. But also in people that have mild TBI, and I will try to reduce this a little bit. In mild TBI, and this is an extract here on the right of the New Zealand study that was one of the first to point out that 1 year after the trauma, 50% of the patients still have had complaints. So protecting the brain against all these things, we only have one brain, we should protect it, and I think that's a no-brainer. In children, it's even more important because they are little people in development, and if a child has a mild TBI, it will catch up the gap eventually with the peers when the learning capabilities are still largely intact, but in moderate and severe TBI, that's not the case, and the gap will remain, or the gap will even become larger. And we know very well from several studies that IQ reductions in children with severe TBI are actually a huge problem. And finally, older adults, well, there we know very well that outcome is usually quite grim. This is a graph from a meta-analysis where the pooled incidence of unfavorable outcome in older adults across studies was 65%. So these are all reasons to engage in prevention. There's actually one more reason, and that is that when you look at mortality, about 2/3 of trauma mortality happens before patients actually get to the hospital, before they get medical help. And that's due to exsanguination, but particularly also to TBI. And there was an old study in San Diego by Klauber, and Marshall was involved in that. It was the start of the traumatic coma database, where they found that the pre-hospital deaths among their TBI population, and that was then only looking at TBI, were 65%. It's quite a high number, and I don't know if that is still the case, but the only way we can potentially help these people is by prevention. And then finally, so when we look at mortality and morbidity, that's one thing, or that's two things, but the third thing is the neurodegeneration that is initiated at the time of the trauma. It will not become apparent in everybody, but we do know that it is there, and it adds on to the sequelae of TBI, and even in subconcussive or non-symptomatic head impacts. We know that from the famous articles that have been done in sports. This is one of the William Stewart group in Glasgow, that the hazard risk for neurodegeneration is higher in professional soccer players. It's also been confirmed in other categories of athletes that sustain head impacts. So that's another reason from a different perspective to prevent a head impact and to protect our brains. I will try to guide you a little bit through the history of head injury mechanics research, how that came. And it's actually, well, surprising that when cars were getting invented and produced, they quite swiftly also led to accidents. So the first car accident was reported in a New York newspaper in 1896. But it was only after World War II, in the 50s and the 60s, when the roads were crowded with more and more cars, and when the cars became stronger, more powerful, and faster, that the automotive industry actually started investing time and research efforts into this phenomenon of TBI and other injuries caused by the automotive industry or by cars themselves. And one of the first groups that actually worked on this in collaboration with the industry was the Wayne State University. And they did experiments there where it was very rudimental and at the start. They with a hammer, kind of a hammer, with an accelerometer, they impacted cadaver heads. And what they could look at in cadaver heads, there's not a lot you can look at. They looked at fractures, skull fractures that were produced by that. And then they tried to investigate and map the relation between the magnitude and the pulse duration of the linear acceleration onto the head and the appearance of a skull fracture. And that resulted in a very, landmark graph that you see on the left bottom, that was for the first time that they found a relation between linear acceleration characteristics and trauma. And that became the Wayne State University tolerance curve and was the basis for the head injury criterion, which actually looks at the time segment of the pulse duration where the linear acceleration is maximal. The head injury criterion is still nowadays in most protective headgear standards and also in automotive industry standards, the criterion that's being used, although it only looks at linear acceleration. You see here how this is true for bicycle helmets. This is the drop apparatus device that is used to test the bicycle helmets and to see if they fulfill the standards. All countries, all big countries, also the EU, for instance, have their own standards. And so, for instance, in the EU, the drop height is 2.5 meters, and the G-force should stay below 250 G, measured with an accelerometer in the head that is subjected to this impact with a helmet, obviously. So, but this is just to say that mostly people will still look at linear acceleration, and this is based on that very old research. While we know, actually, meanwhile, that rotational acceleration is way more damaging to the brain, and that was first found, investigated by Generelli, Tom Generelli. I will come back to that. Was a neurosurgeon in the States, working in Penn University and also in Milwaukee. And Thibault was his engineer, and they did research together on rhesus monkeys and found that rotational acceleration was actually for the brain, then not for the skull, but for the brain, the damaging mechanism. And it was then later on found in several models, and particularly found in element models, that there was a very strong relation between stress and strain induced within the simulation of the brain in the finite element models on the one hand, and rotational velocity and acceleration on the other hand. And that led to other criteria like the brain injury criteria, as you see it here, the BRIC. Then Gambit is another one, head injury power is another one. And those have a way more stronger emphasis on rotational acceleration than they have on linear acceleration. And this brings us to the head injury criteria. So I mentioned HIC and I mentioned Gambit, etc., and the other formula based on rotational acceleration. Those are general head injury criteria. So it's like a yes/no criterion that says you either have or you do not have a head injury when the tolerance curve of that criterion is surpassed. But obviously way better are the lesion-specific tolerance criteria that look for instance, contusion separately, for acute subdural hematomas separately, at the tolerance criteria therefore, and then you can actually come to a very granular approach where you look at, for different sports, different types of accidents that can happen with different types of mechanical input, and then you confront that with a tolerance curve for different types of injuries, and that will give you an idea whether these injuries can happen or not, and you can then design specific protective headgear to prevent these injuries. So how is the research usually done, and what models are being used? Actually, basically 4 models are being used. We can work with human cadavers, and this is research that is not so often done. They have a strong tradition in Penn University and also in Leuven. We've done research on this, where you, for instance, mount accelerometers on the skull of the cadaver, and also you put neutral density accelerometers within the brain parenchyma, and then subject the cadaver to impacts, and then you can correlate the relative motion within the brain and the deformation of the brain to the skull motion, and that obviously gives very relevant input that you can use to design more mathematical or physical models. Physical models have also been used using skulls and filling them with gels, or using models as you see in the pictures. And then obviously animal models to produce injuries and to try to identify tissue level tolerance criteria. So for instance, here the figures that you see are from papers that we published in our Leuven research on piglets, where we try to identify what were exactly the tissue level mechanical criteria to provoke or not to provoke a cerebral contusion. And then finally, finite element models, which are the most often used models, mathematical models in this type of research on head injury, where all the anatomical structures are represented by finite elements that have certain material characteristics and certain linkage with other elements, and that actually creates a kind of a simulation head that can be subjected to the mechanical input as you expect it will happen, or from which you would like to know the output in terms of stresses and strains. And so you see how the end result then is. We do on the right-hand side, you see that we do cadaver experiments. For instance, we try to plot the relative motion of the brain or the amplitude of certain mechanical characteristics. And then you can use that as input for the finite element models. On the other hand, you see it on the left-hand side, you then use the finite element models to imply on them the mechanical input, the mechanical characteristics as you get these from accident reconstructions. And then you can see in certain types of accidents what the relation is between the stresses and the strains that you calculate from your finite element model on the one hand, and the injuries that the patient had sustained. This is usually used in sports injuries because the big advantage of sports injuries is that there are video footage available of these traumas when these injuries actually occur. Because if you don't have that information, it's very hard to do an accident reconstruction. And there are international databases of these accidents with both the mechanical information and the injury information to help to refine the finite element models. But to be honest, these databases are very limited. There are not so many accidents cases that are in there, and the development of finite element models is still something with lots of uncertainties. This is part of our Leuven research. So we did experiments on piglets where with a controlled cortical impactor tried to to provoke contusions, and then we actually started from very minimal impacts on the cortex that provoked no contusion to impacts that did provoke contusion based on MRI imaging, and then tried to identify the mechanical characteristics and come up with a tolerance curve. And you see, actually, it was way more difficult than expected. You would think this is simple research, but it's actually not. There's an inherent variability of the trauma response that the injuries will have on the one hand, but also the basic mechanical characteristics of the impact is actually very basic, what you can get from it. And then you need artificial intelligence approaches to try to cover the different scenarios and the different uncertainties. But most of the uncertainties actually come from the accident reconstructions, and this is also work from our group where we showed that actually in accidents that were quite strongly documented, even then, there are so many uncertainties that will have a huge influence of the end result of the end result being the forces and the accelerations applied to the head. For instance, the stiffness of the windshield, the stiffness of the different parts of the car. Usually we do not have very precise data on that. But for instance, also this is a bicycle accident that is simulated here. The crank rotation, so that the exact position of the pedals when the accident happened has quite a strong influence of how the mechanical input on the body and then eventually on the head will look like. And this is usually information that we do not have. So accident reconstruction is not an easy thing. So but coming back to the fact that rotational acceleration has been demonstrated on numerous occasions to be the most damaging injury to the brain. Actually, we know it also from boxing. The according to me, very silly game of boxing is trying to provoke a concussion to the other player, and you can only do that by provoking a very violent rotational acceleration of the head, either by an uppercut, as you see here, or by a sideways blow, as you see here. It was Tom Gianarelli. I show a picture of him here. He did actually great research to understand this, and then had to stop his research because the animal welfare organizations went after him, and he had to stop. But the insights we learned from his research were actually very profound and very great. And he found in the beginning of his research that only angular motions to the head can cause concussions. But he only could provoke concussions, and then the animal woke up after a short while. And what he actually wanted to replicate was these accidents that they saw in high energy car accidents where the victim never woke up anymore, and that then on autopsy appeared to be diffuse axonal injury, as it was called at the time. He wanted to provoke that. He wanted to understand what caused that. So he designed a second device that produced a non-impact motion to the head. That was the PEN-1 device, and it was a sagittal motion that it provoked, but with way higher acceleration. It was a way stronger pneumatic device. And what he saw there in those experiments is that he provoked acute subdural hematomas from bridging vein rupture. So he was still not happy because he still did not understand what brought about diffuse axonal injury. And he could only do it with then again a new device, the PEN-2 device, in which they could do sagittal but also coronal motions to the head, but with very high acceleration amplitude, but also with longer pulse duration. And it was those pulses with long pulse duration and coronal motion that did provoke finally the diffuse axonal injury that he was trying to achieve. And so the way we understand this is that acute subdural hematomas, at least from a bridging vein rupture, are provoked by a rotational motion in the sagittal plane with a short pulse duration. And actually what you get there is a stress on the bridging vein that will be elongated and that will finally tear. And so that mechanism is responsible for bridging vein tear. On the other hand, diffuse axonal injury, we know where that usually happens, in the corpus callosum and in the basal ganglia and the mesencephalon. And this is because the falx is there, and the falx limits the motion, and the brain will get deformed in the deeper areas that are surrounding the falx. And this particularly happens, as you can understand, in coronal motion. And for that, you need this a rotational acceleration, again with a high acceleration amplitude, but this time with a long pulse duration to provoke deformation. Because if you have a very short pulse duration, you will only get a stiff motion of the brain relative to the skull. To have deformations of the brain, at least with a certain strength, you need, and a certain shear stress, you need long pulse durations, and it needs to be in the coronal plane. And this is obviously mostly provoked by car accidents, but not limited to car accidents. But this is a schematic representation of different brain injuries, traumatic brain injuries and head injuries as we know them, and how they are actually provoked. So for a skull fracture, this is not provoked by inertial loading. This is provoked by the direct contact, and also an underlying contusion can be provoked by that contact loading. And these then can lead, a skull fracture can lead to an extradural hematoma, or the skull bending can lead to extradural hematomas. And several contusions can get worse and lead to an intracerebral hematoma, can transverse through the pia and the arachnoid and provoke an acute subdural, or also cause subarachnoid blood. But that's secondary. So it's not secondary injury, it's still primary injury, but it originates originally from a contusion. But most of the injuries, as you see, are provoked by inertial loading. And for that, the rotational motion is way more important. And these provoke cerebral contusions, bridging vein rupture, as I explained, diffuse axonal injury, as I explained, and also subarachnoid hemorrhage from very small tears in small cortical arterioles. So this is the way to understand it mechanically. And I will quickly go over some research that was done in Leuven and internationally to try to find tolerance criteria for these different injuries. So for skull fracture, Yoganandan in the 90s did crush injuries, and he found that if you look at the force deflection curve, the force actually goes up, and at a certain deflection, then suddenly the force goes down. And that was the moment that the fracture occurred. And if you then calculate the area under the curve, that's the energy that you needed, that the skull actually absorbed before the fracture occurred. So the idea was that it's absorption of energy, and depending on the location on the skull where the impact occurs, the absorption criterion will differ. So we did experiments in Leuven with a double pendulum, one that caused the impact and one that had the skull that actually replicated the mass of the head and the neck together. And well, this produced lots of data, very interesting experiments. And we could replicate those force deflection curves also in a dynamic situation. But the answer was that energy absorption is not the sole criterion. So that's a little bit too simplistic. We could not come up with an energy criterion as such. And so far, there is no better criterion. Nobody actually really picked this up and produced a better criterion. So we don't really know. For diffuse axonal injury, the group of Thibault, that was one of the collaborators of Tom Gennarelli, and then Susan Margulies also stepped in, and Dr. Duhaime, who is a neurosurgeon as well, and they did research on diffuse axonal injury, originally with the physical model, and then they replicated that on the rhesus monkeys, and on they recalculated to human sizes of brain and skull, and so they came up with a rotational acceleration and rotational velocity criterion, as you see in the graph. So this is for diffuse axonal injury. Several groups did work on tolerance curves for acute subdural hematomas. On the left, you see the original curve by Gennarelli. The middle one is by a German pathologist, Dr. Löwenhielm. And then we added our own experiments to the ones of Löwenhielm, and came up with a tolerance curve that was published already 20 years ago almost. So it's quite old research. And that is quite a specific tolerance criterion for bridging vein rupture. For contusions, most contusions occur in the frontotemporal lobes. This is explained by the amplitude of the relative motion of the skull, of the brain towards the skull, that is most pronounced in these areas. And we have proven that with quasi-static MRI experiments and also with cadaver experiments that this is the case. And so it's also rotational acceleration that will provoke these relative skull-brain motions. And a criterion will look more or less like this, but this is this research is not finished. This is like a preliminary curve that we established in Leuven. And also for concussions, and this is in football players, tolerance curve has been developed, as you see here, with the risk of injury plotted on the curve, and as you see, and as I explained, it's also a rotational acceleration criterion. So what is still to do? Well, actually, there's a lot to do. The skull fracture tolerance criteria is not finished, so we need to investigate this better. We also need to refine the very conceptual contusion tolerance curve. We need to reduce uncertainties, both in the models and in the accident in the accident reconstructions. And then actually, when we have tolerance criteria, we need to make them age-specific and sex-specific, and also size-specific. Not everyone has the same size of skull and brain, and this is obviously, we need lots of data to get there. This is work that still needs to be done. And on top of that, different accident types with their own set of mechanical inputs need to be need to be aligned, need to be discriminated by cluster analyses. And so then, if you have all that, then you can try to develop more specific protective headgear that goes a little bit away from the very generic approach for protective headgear that is being applied now. So why is this important to try to understand the different mechanical mechanisms that are causing brain injuries? Well, first of all, I must say that from doing this research and over the years and being into that, I understand the development of primary traumatic brain injuries much better, I think. I look at the scan a little bit with a mechanical perspective, and also when I look at the scan, for instance, with contusions, there's a whole lot of things that go through my mind, how this accident actually happened and what I can expect next and what very likely the next scan will look like. That's one thing. The other thing is, when we want to do animal model research on TBI, and when we want to replicate severe human TBI, we have to understand that the rodent research is different research. It obviously investigates molecular pathways, etc., that are valid in TBI. That's definitely sure, but it's not a real model that replicates severe human TBI. So to replicate severe human TBI, you need the same mechanical characteristics that provoke it. So you need rotational acceleration. So you need, for instance, and you see here, this is research again from Penn University, where they looked into different ways to cause high rotational acceleration on pig heads and to try to develop severe human TBI in pigs. And they succeeded in that to a certain extent. We're trying to replicate that in Leuven because we need it for the research we're doing. And I must say that it's actually very difficult because you need a very strong head impacts, and not just a non-impact head pulses, but also you actually do need an impact to add to that to get rotational acceleration magnitudes that are high enough to get brain injury. And the third thing, obviously, is when you understand this, you need this to develop better prevention, to reduce TBI incidence and the sequelae of TBI, and particularly to reduce the percentage of TBI deaths that will occur prior to hospital admission. And I have to discriminate here two principles, and it's easy to understand, but people often mix them. There's safety and there's protection. Safety means developing circumstances, home interiors, road infrastructure in such a way that you reduce the incidence of accidents. So this is prevention of accidents. But still, when you develop the safest infrastructure, accidents can still happen. So protection is something different. Protection is the prevention of injuries when an accident happens. For instance, with seatbelts, with airbags, with helmets. That's a different thing. And I mentioned this here because there are groups, for instance, the bicycle pedal cyclist lobby in Belgium and the Netherlands. They are against legislation on bicycle helmets because they say that's victim blaming. You should not have the victims wear something. The government should invest in safer roads. And that's obviously true. The authorities should do that. But it goes in parallel because safer roads, that's safety. And helmets, that's protection. It's different things that work in parallel. But both are prevention, and prevention is usually underrated by healthcare professionals. And I think we also should give an example in that. And I quickly go into the bicycle helmet case because my doctoral thesis, we did experiments to identify generic mechanisms, but the goal of my doctoral thesis was to develop safer bicycle helmets. We didn't really get there, but I'm also into the research that is associated with that. And bicycle helmets actually do work. They do reduce injuries and injury severity, and that's proven in numerous circumstances. And there's a Cochrane systematic review. There's also the systematic review by Atwell that is usually cited, and that is also the best. So the odds ratio for severe head injury, traumatic brain injury, facial injury as well, and fatal head injury is reduced by, and the ratios differ a little bit, but approximately half. So half of the injuries and half of the severe outcomes of that you can actually prevent by bicycle helmets. In Belgium, for instance, we have about 100 fatal bicycle injuries per year. So if bicycle helmets would be compulsory, we would reduce about half of that. So we would win 50 human lives. Is that worth a bicycle helmet legislation? I don't know. That's for the politicians, but we should provide the correct data to underpin this. So this is bicycle helmets, as you know that. Bicycle helmets are protection, as are seatbelts and airbags. Airbags have had a huge impact. Seatbelts as well, but particularly airbags. I was a trainee when the airbags came, and we had about more than 50 severe traumatic brain injuries a year in Leuven, and it got reduced to 10-15 per year after the airbags were introduced in the 90s. So that's protection. Another thing is prevention. So you see here a bicycle or a pedal cyclist who wears a helmet. The helmet is protection, but all the other measures are prevention. The headlight, the reflector, the bike that fits, brightly colored clothing, etc. That's not protective, obviously, but that is to prevent an accident from happening. And it's the same what you do with speed cameras and with campaigns to reduce speed and to reduce alcohol consumption before getting into a car. And also, for instance, helmets that are being worn and all the safety strategies that apply to wharves. And then a third thing is awareness in sports. In sports, it's mainly about concussion, and many coaches and people that are involved in the sport federation cannot recognize concussion and cannot take the accurate measures. So for that, the SCAT tool has been really really helpful. So I won't go into the details of that, but also in sports, prevention is actually very important. And in most of the professional sport players, this is now introduced and working quite well, I think. But there's not only professional athletes, there's many young people and older people as well that play sports just as a hobby, and that should apply there as well. And many of the clubs actually do not have a clue. So we still have work to do there. And then surprisingly, and I come to my last slides, there's also resistance. You wouldn't expect this, but I know the arguments of the anti-bicycle helmet lobby quite well, and I very often go in discussion with these people, and so they actually want to avoid any negative association with pedal cycling, because pedal cycling is healthy and is good for the environment, etc., which is obviously true, but it is also true that the risk is obviously low, but there is a small risk for accidents, and helmets can protect you against, can protect your brain at least against that. And then they come up with arguments like, well, if you wear a helmet, you will take more risks. And if you wear a helmet, the automobilist will also take more risks because he sees that you are already protected. Also, the argument is that there will be less people using their bicycle when you have too much emphasis, and particularly when there's bicycle helmet legislation. And so they come up with all kind of a little bit emotional arguments that are against helmets, and people pick that up, and that's very confusing to the general public. And I can only emphasize that it is true that bicycle helmet legislation does have an impact on the number of people that use the bicycle, but it's usually temporary. And after a while, and that's been very clearly proven, people use their bicycles just as they did before, and particularly children. There is no effect on children, because children will not take the car because they have to wear a bicycle helmet. They will find the bicycle helmet not sexy, that's true, but they have no alternative for their mobility, so they will keep on using their bicycle. So these are things that we should at least consider. So to conclude, prevention is the most powerful weapon against TBI. The research is ongoing. There is still room for improvement. Unfortunately, there's not so many groups that work on this. And I think that we, doctors in general, but also neurosurgeons, should be the strongest advocates for prevention. Thank you so much, and I will stop sharing.
Thank you so much, Bart. Excellent overview, and a really important topic also in Sweden regarding the helmets. Should we go on with Alex's talk and then have the questions at the end? What do you think?
Probably that's best, I think.
All right. Alex, the floor is yours.
Thank you, Elham. Thank you, Bart. Crazy, all the stuff that Uswell in person did in terms of these, understanding the injury and understanding the mechanism, etc., about these experiments. It's impressive every time. So I really wonder how you look at those images, like you said, and how you look at them differently in terms of how the mechanisms went, and then what might come next, etc. So probably different view with these, the experiments in the background. But we can discuss this, I guess. So I'll share my screen. Okay. So is it the same as for Bart's talk?
Yes.
So okay,
No,
great.
this looks
Okay,
great.
all right. So I'll just try to minimize the nice faces here. And okay, anyway. All right. So my talk is a little different, I would say. So it really focuses on one population, which is the aging population. And as always, because I've talked about this a couple of times now, I want to dive into three main aspects. I think there's nothing to disclose for me for this talk here. First of all, how the epidemiology changes and why we talk about the aging population in the context of TBI. It's quite obvious for many of us, but I want to show some data on this. Then I think this is quite interesting for many of you guys, insights into faults. So how faults can be better understood, and what this helps us maybe to actually do to prevent them. And this is basically the third thing, and it mainly focuses on a preventive trial that we are currently doing, and I want to tell you a little bit about this and give you some examples of what you can already do now. So this is to just dive into it right away. This is a very large graph with data from the German Federal Bureau of Statistics. And it shows two different time points. One, the blue lines, is from the year 2000, and the other one is from the year 2018. So nearly 20 years apart. And first of all, the overall number of TBIs that are treated in hospital, so this is in-hospital TBI treatment, is going up. So it's nearly 100,000 more. So this is quite relevant. But as you can see on the right side with the red box, this is mainly driven by the not only old, but very old population, and not so much by the, let's say, mid or young population, but really by the older folks. So there is a very strong shift in this kind of epidemiological statistic data, at least within Germany, and also a more detailed analysis here from a part of Germany, again Germany, with in the south with a very large cohort size, 24,000 people. And here authors looked at people who are old, more than 65 years, and this is age stratified percentages. And they looked at people living independent, largest population, at home, but with some care, and then in a care home. And this is the rate of hospital admissions due to TBI. And overall, this is 4.9%. Then in all the folks at home, independent, this is 3.4%. But then if you already need care, and then if you are in a care home, this gets really high. So obviously, this is somehow the population that is most affected, and that, to be honest, we see in our everyday practice in hospitals. And this is not only relevant or a thing in Germany, in Europe at least. So this is data from Andrew Maas's Lancet Neurology paper. In Europe, the incidence of TBI is rising, the caseload is rising. TBI patients are generally getting older, like I've shown in Germany as well. And then most admissions are mild injuries. And then the most common events leading to the TBIs are falls. So that's quite new, I would say, falls. We have a German TBI registry nowadays, and we have looked at the epidemiology of TBIs in Germany in the recent years, more specifically here as well. This is data on patients who are treated on the ICU. So this is a little bit more specific, so more severe injuries. But even there, so 18 centers recruiting currently over 1,000 patients in the analysis. And the rate of falls is now more than half of the people. So 56% of those people overall fall, that they have TBI and then get treated on the ICU. And a third of them is happening at home. And as you can see here, the mean age in this cohort is already also nearly 60 years. And this is really the last bit of statistics slide, but that's quite interesting. If you think about falls, you would suspect that not only something is injured in the head, but that there are other injuries. You would think about hip fractures and other fractures. And if you look at this is again age adjusted, but the overall incidence of fractures per year here is not rising, but is rather going down here a little bit and then stagnant. Whereas the head injuries, TBIs, and also fractures of the cervical spine, for example, over the years in the age-adjusted population is rising. So there's a difference. Although, okay, people get older, they seem to fall a lot, but the injuries are mainly TBI. So why is that? And I want to show you a couple of videos. So this is from a large video database that is openly accessible, the Vancouver Video Fall Database. And there's, I think, over 2,000 videos. And it's sometimes really horrifying. They are filmed in long-term care facilities. And there's a lot of examples. And those videos have been heavily analyzed. So what you've seen here is typical case where the patient, or not the patient, but the person rotates while she falls, and she tries to avoid a facial impact. And we'll see in the next slide that this is quite important to do that. And then you can also see that there's a attempted protective response, but it's not really sufficient. So landing backwards, and this is what many of those videos show, seems to be the preferred strategy for people, for those older people, to potentially prevent injury. And this works. So this is analysis of many of those videos. And you can see fall characteristics. And then here, any injury versus no injury, and serious injury versus no injury. So if people landed backwards versus when they landed forwards or sideways, their odds for having any injury versus no injury were heavily increased when they landed forwards and a little bit as well when they landed sideways. And then for a serious injury, this is even more pronounced here. So what it means is, okay, so if you land forwards, that's quite bad. And then sideways, also not so good. But then if you land backwards, overall, less injuries and less serious injuries. But, and this is now our problem, neurosurgical problem. The most common first impact for those people is hip and pelvis. Okay. And they have a fairly low probability of injury, as you've seen the slide from the German Bureau of Statistics. So those numbers, they don't go up. But if those patients, they also come on the head, and this is in the videos that have been analyzed in around 30% of cases, then they have more serious injuries. And this produces obviously TBIs. And another way to look at this, you can see it again here, is as a kind of multiple impact injury. So, this lady, you don't know what's happening, but maybe I don't know what the reaction was, but then she stumbled and fell backwards and she hit her head. And those patients, they have multiple hits. So again, a hip, pelvis, sometimes the upper cervical spine, and then head in some cases. And then when the head is injured, this is a problem. Another way to look at this is using sensor data. This has been done quite expensively as well. Here is data from the Parsine Consortium. Here, patients have been equipped with a smartphone, Samsung Galaxy phone, and this has accelerometer and gyrometer data. And you can see how a normal patient stands and then walks, and then obviously something happens. Patient fell when he opened the door. And then you can see how the body axis change and how the patient basically stands up again and walks. And this has been done with many patients as well. This is, for example, a case where a demented patient stands and walks quite differently, falls, and then takes some time to rotate, frontal or forwards, and then to stand up again. And this, together with additional sensor data, can actually tell you that a head impact has occurred. Another case, even more, I think, astonishing, is this atypical Parkinson syndrome patient. Very different sensory information. Here, walks and then falls backward, and then tries to stand up and walks again. And also, this is a fall with a potential injurious head injury. What's interesting is that when you talk about the falls to those patients, what they will report is in many cases not what happened. So they will remember the fall differently to what really happens. And while many, for example, here say, okay, I fell, for example, forward, in the reality they fell backward. So there's this 25% discrepancy in cases. And this is very important to know if you want to talk about fall prevention later on. Okay, talking about fall prevention. So this is not something that is new, and is especially not something that traumatologists or neuro people are the first to actually do something about. But there's a lot of work done on fall prevention, mainly by geriatricians, for example. And this is a global guideline for falls in older people and older adults, published, I think, 2 or 3 years ago. And it's a really robust algorithm that is shown here. And this is not focusing on TBI, obviously, but on falls in general. And if you look at the algorithm, you can see that much of this is focusing on secondary prevention when a fault has already happened. And this is one of the problems, and you can see it up here. You have to do opportunistic case finding, because people will not report that they had fall, at least to older people. And it's to prevent faults, you would have to actively ask about it and then realize that faults do happen, and then you can try to act. So I just want to take a couple of, let's say, important findings of this guideline that I want to share. So preventing fault and injuries obviously requires an approach with different disciplines. I think this is quite, if you work with those people, at least this is really easy to understand. So if you're the neurosurgeon, you tell them something, this will not work. So you need occupational therapists, physiotherapists, geriatrician maybe. There are general practitioner, etc. So this is a team effort. Then they may not report faults again, so you have to proactively talk about this, address this as a potential topic, and you have to address multiple risks. And then there's a couple of interventions that have been used, and they always try to address multiple domains. And if they are delivered, and if they are individualized, there is data, obviously good data, that shows that they can be effective in preventing additional falls. And what is quite clear to me now working with those people, with older people, is that you really have to take into account their priorities and beliefs, and you have to take into account their families, etc., to manage this appropriately. So this is, I think, probably similar with kids. I didn't work with kids, but it's definitely different to, let's say, normal aged people. Okay, the bad thing is that all of this is not specific for TBI. And while we've seen that falls in general are a problem and they cause a couple of different injuries, TBI is one of the most prominent ones, and also one of the most disastrous ones when it happens. So yeah, that's something we have to change. And the good thing is that there's a lot of intervention for fall prevention in general that have been tested and have been applied to different groups. And we can basically, we do not have to reinvent the wheel, but we can take from those. And this is just a list. In the guidelines, there's a complete set of all the potential interventions that are currently available. And I want to show you what we now try to do in Germany, in Heidelberg, and in Ludwigshafen, where I'm working now, and also in Berlin. We have developed a study that aims to prospectively recruit over 100 patients, all the patients who have a mild TBI and had a fall. Okay. So the current recruiting status is 12. So this just started, and it's quite difficult to get folks into the study, and it can give a couple of very preliminary results later on. But we hope to have more patients soon, and everybody who's interested after this talk to also do something like this with the study at first, but then later on maybe really installing some kind of structure for this, please reach out to me. So this is our team in Heidelberg, again, team effort. And what we want to do is we want to include those patients. It's important for them to live nearby. That's one of the limiting things for older people already. If you have a large radius for them to come back to you to the hospital, they will not do it. They have to have essential language skills, hearing and vision, no serious terminal illnesses, etc. So this is quite difficult with the neurological illnesses at least. And then the study looks like this. Patients are enrolled, and then they receive fairly intense assessment for up to 2 hours. And then all the people during this assessment, they really get tired. And this is one of the main barriers for this kind of study and experiment. But then they get a sensor applied to their back, can shower with the sensor, and the sensor is tracking activity, because we know that what they will report is not really what happens. And then they send the sensor back, we'll assess the data, we'll assess the data of the assessment, and then they come back to us, and then we give them individualized recommendations based off a set of different available interventions for what they individually could do to prevent another fall. And then they get followed up, and I mean, we'll talk about quality of life, we talk about this and that, but also whether or not the recommendations have been implemented and whether or not additional falls have occurred. Then a subgroup of them is also interviewed in a co-design kind of fashion where they are invited with their caregivers, and you really try to find out what has worked and what did not. And this is why this is multi-professional. So this is done by medical doctors, but also by occupational therapists and by physical therapists. So parts of the things that we do for those patients is really not done by us as doctors. For example, one of our occupational therapists, he goes, if it's possible, to patients at their home and looks at their home, and then has a software called Housing Enabler, and then he can assess, dangerous areas in the house where they might, trip and fall and stuff like this. Okay. It's important to not only have a mobility diary, but also a sensor for this kind of a study, because it will give you real data, not just what patients reported. And this is just a study on those individual recommendations. So the domains they address are basically mobility and then medication. So this is a very important topic for all the people. So you will look at multi-medication adjustment. You will look at all risk increasing drugs, etc. Then vision, we do a vision check and then refer to an ophthalmologist if abnormalities are found with their glasses, etc. And then again, home environment. So this can be done at home or with pictures, etc. And then we provide fall prevention materials, provide letters to general practitioner. And then when they come back, this is part of the follow-up. So a couple of quality of life measures, pain, etc. And also this co-design process with a small subset of patients where really you want to know why did something not work in terms of the recommendations and why some other things were quite easy for them to do. We want to identify risk factors of second TBIs and other fall-related injuries, and then provide them specific recommendations. That's the primary aim. And we also want to know what are barriers and facilitators and whether or not this already affected mobility and quality of life. But ultimately, this leads to the development of a protocol for an interventional study where really we want to test this and do this with you guys and do this in a multi-center way. And then after that, we want to do it for every patient. Okay, so this is a lot about the study. I just want to give you like a quick update. So 12 patients in. Every patient so far, we found something like one very strong driver predictor for an additional injury. Might it be a cardiac problem? Might it be a problem with the vision? Might it be obvious problems in the house? So we'll have to analyze this, etc. But there were so far always at least one or multiple good reasons, and we hope that if you change them, this might already affect something. So key messages here. Fall-related TBIs are very common in all adults. They are often neglected. So this is something you can specifically ask about, even within your families maybe. Then we do not have tools for TBI-specific risk assessment and prevention at hand right now, but studies are underway. And you have to understand that secondary prevention is already early rehabilitation in a way. So this really comes together very, very, very closely. So all the things you do in terms of mobility, etc., they are already early rehabilitation measures. And then something that you in your practice, you can really already do. And after, again, working with those folks, it really makes sense. So if you have a patient comes in, has a TBI, mild injury, fall, older person, and for some reasons, a patient is admitted, maybe a complicated mild TBI, some blood. We not just let him lie there and try to discharge him home or wherever the next day, but look at the medication. Or you can already check, there's easy software to do this. What is maybe not good for in combination, etc. And then you can recommend things. You can recommend new cardio workup if you think that might be cardiac problem. You can have a footwear check if you look at the footwear that those people wear. You can have a look at how they handle their rollator, and you can send them to training, and then obviously PT, for example. And new psychological testing, in some cases, you could just refer. Vision control as well. And then use the tool, if you have it, to plan cognitive rehab. It's not very specific, but it's better than nothing. And with this, I want to end. And I think that probably Bart and Elham have seen this video so many times, but yeah, I hope many of you didn't, because it just shows how this can actually happen and how those people can actually all come to your ER and have a TBI. So, thank you. I think that's all. And now we can start the discussion.
Thank you so much, Alex and Bart. I can just check the Q&A that there was no question. There was one question in the chat. And the question was, has anyone looked at in-home visits to assess the living space for fall risks that could be eliminated?
Yeah, so this is something that, it's obviously very time. So one of the things that becomes clear is that all of these measures, many of them really require somebody who organizes this and does this, and it's very difficult, obviously, for healthcare system to provide this, because we're talking about many patients, and if they do not have relatives and family members that can be trained and can be implemented to do this, one of the things that would be good would be some kind of warden, who looks at a larger group of those folks at the same time. I think this has been done for stroke, for example, in Germany, and this is done for kids with a couple of different diseases. So maybe that's one of the things that could be done, because for you and your hospital to actually go to the patient's home and look at the housing things. You're not a specialist, first of all, and then it's just crazy in terms of how much time it costs. There's ways to look at this via photos, and there's a housing enabler app where you can also kind of sketch based on their what they tell you, but it's always it's really different if you go there and check it out yourself. And then, for example, one of the things that we realized with the 12 patients, I think 3 or 4, you go to their house, you never talk about alcohol, right?
No.
Never an issue. You go to their house, and then the first thing they offer you is a drink. Sparkling wine for older lady, and then they tell you that later on they will go to the park and have another bottle of sparkling wine, and then this is just going to their house, being in the environment. This is obviously a potential driver for risk as well. So just this happened a couple of times already. So yeah, but yeah, to answer your question, this is something we do in the study with this, but outside of the study, it would not be possible, I think.
So maybe the wearables and the remote devices that can be used is the way forward to assess and help this older population for prevention.
Very good point. Yeah.
I think Bart has a question.
Yes, indeed. If there's no questions from the audience, I have a couple of questions for you, Alex, and thanks for a great talk. I've seen parts of the talk already a couple of times, but every time I discover new things. And for instance, so the rate of TBI and of accidents, of falls, is higher in nursing homes than in a home situation. But why is that? Because I can imagine that, or I know that a care home and a nursing home has a more cleaner infrastructure and less carpets, etc. But is it because people are frailer when they get in a nursing home? They're frailer than they are at home?
I cannot give you the perfect answer, but I think there's two things. One is the frailty, because there's a bias towards them being frailer than the ones still living at home, and the other thing is a reporting bias. So the home will send them to the hospital every time they have a minor injury or fall, and if they live at home, independent or even with home care, this will be neglected in many cases. So that's one of, I think that's those two answers. But you're right. So this facility, they usually provide a lot of measures to already prevent falls with very basic means. And it's a good observation. But I think it's those two effects. If you think about wearables or point of care devices, if you would, because they will see all the falls, right? Whereas outside of those facilities, again, might be neglected. So for them, to see a fall, to realize that there's a fall, but to assess whether or not this is a relevant fall is quite difficult. So they will probably really send the patient to the hospital every time. If you give them a means of, checking, point of care, whether or not this might be less severe, like a biomarker with an easy readout, I think this can already, at least in Germany, reduce rates of transportation to and from the hospital quite a lot. So primary prevention, obviously, secondary prevention, also this kind of triage, whether or not this is a severe injury or more severe. But okay, it's another topic, I think.
Yeah. And when the age-adjusted incidence of hip fractures remains rather stable while TBI goes up, is that the result of an intervention? Is it because of better osteoporosis care that hip fractures do not increase, because the demographic shift is there? So what can we learn from that being stable of the hip fracture curve?
It just means that even if you're old and society gets older and you manage to fall backwards, which, many of those falls actually, that's how they occur, you will land on your hip and you will land on other body parts, but the risk of them to be injured, to have a fracture, stays, does not increase with additional age. But if you fall on your head, if this, this extends fully, and if you do not have those protective means with your arms to prevent this, if your head touches the ground at the end, cervical spine head, the injury is there and is more severe than the potential fracture of the hip. So it's a good strategy to fall backwards, because for the hip, etc., it helps. But if unfortunately you're old and you cannot manage to protect your head and you have the head impact, then this becomes a problem. So, but it's still better to land on frontally. Obviously, this is the worst that might. If you have seen folks just obviously, this is a very more serious type of injury pattern. And I think it might be other things as well, as you said, osteoporosis, maybe a more active, more stability overall in terms of lower body strength and training. But I think it also just shows that this triple or multiple impact is a real problem.
Yeah. Okay, thank you. So they need helmets.
Yeah, just
helmets at home, 24/7.
Yeah, but you're laughing. So I think there were ideas to roll out very specific materials for the floors in hospitals and care facilities, with that they absorb the force, and they at the end less expensive potentially than having all patients going to the hospitals all the time. But and a helmet could be the same, but helmet is always, again, a compliance issue, I guess.
Yes, that's the... Yeah. We have one question here in chat. Have you seen any link between socioeconomics and risk of falls?
Very good question. I didn't, but I would suspect that there's, like with a lot of things, there might also be a link.
Yeah.
Where less, lower socioeconomic status, maybe, more frailty, but it's just guesses. So Well, maybe less education equals less, prevention from yourself already, or your family, from your surroundings.
Because I mean, if you see the curves of increasing falls within the elderly, the cost should also have that increase in the society as well. So
I think so, yeah.
reasonable. I have one question for Bart regarding, you talked about the helmets. So do you think the MIPS helmets do actually work for the rotational injuries?
I think so. Well, I think so, but unfortunately, we do not have good data from the field, to prove it. But I think it's definitely very useful conceptually, at least. I mean, we have data from the lab that shows that reducing purposefully reducing rotational acceleration, should reduce injuries. And we know these people. It's from Stockholm, right? It's KTH, where this was invented. There are other strategies. Other helmet manufacturers have implemented other strategies. The main thing is testing it, and so getting rotational acceleration tests into the standards. And this has not succeeded. So there is a principle accepted by the EU that this should get into the standards. But then the next question is how? Because it's most of these tests are difficult in design, and the reproducibility is still a little bit problematic, and people are working on that. And once we are getting there, then probably helmet manufacturers will have to implement extra strategies into their helmet design to pass the test. So this is work in progress. This will likely happen, but we're not yet there. Yeah. I have a helmet with MIPS.
Yes, we do as well. So
yeah.
Sure.
Bart, can I ask you something as well?
Sure.
Are you aware of any studies or study that for bike helmet in terms of their preventive effect? Is there any like real world data? I think there's data on motorcycle helmet usage in Taiwan. I've read, I think, one study where they can actually show that this, decreases the rate of severe head injuries. Is there anything like available on bike helmets?
But you mean that data
that if by law, a region, a city, a country, there is all right.
So these systematic reviews that I was showing are largely based on studies in regions in the world where there is helmet legislation, and where they compare
also
before
for
and
bikes.
after. For bicycles, yeah, definitely.
Okay. So I thought, so it was clear for me for motor bicycles and also for cars, but for bikes you could argue, okay, is the velocity, etc. Is it that intense? But so this was based on bike. Okay.
So the evidence is there, and even so, people would use as an argument that a helmet cannot protect against everything. Obviously, that's true. Cannot protect against any impact. So if a car hits you, that will not be protective. This is actually not true, because it also protects in accidents where the pedal cyclist is hit by a car. Because usually when you're hit by a motorized vehicle, the impact with the car may be on your head, but usually is not. The impact on the head is from falling on the ground. So you have more than one impact, so to say. There's a second one and a third one. And in these second and third impacts, where you fall on the ground and hit the ground with your head, the bicycle helmet will definitely help to protect you. So even there, and that's been shown in some of these studies, that also the severity of the injuries was less, particularly when they looked at accidents with motorized vehicles. So the evidence is definitely there.
Okay. And e-scooter, I mean, this is very new topic, but I mean, you could probably apply to e-scooters as well. I think there's no legislation yet, at least.
No.
And Germany does not.
Yeah, no, in
Yeah.
Belgium neither, and that's a bit problematic because these people can come with very severe TBIs, as we probably all know. In the meantime, yeah. So
Yeah.
I hope that legislation will come there. Yeah.
We have a huge problem in Sweden as well for the e-scooters, and in particular when they go multiple persons or they
Yeah.
have their kids on the e-scooter and no helmet, so it's an issue. We have another question here. Is increased life expectancy, isn't it a cause of raise in more TBIs in old age statistics and drug increased falls?
Yeah.
Probably, yeah.
Absolutely. Yeah.
Developed world.
And to add to that, Alex, I'm really admiring you for your study and for what you do there. But if I think about logistics of your key messages, the number of older people that come to the emergency department with a minor or mild TBI, that's huge. I mean, that's several per day. So who can talk with these people, identify risks, fall risks, and well, everything you explained. It's probably not a neurosurgeon that will do that. We usually even don't see these people. It's only when there's a little bit of blood of the scan that they ask a consult. So how should we organize that?
Yeah, we thought about it. So what we want to have is risk assessment in the ER done by a neurosurgeon, and then you would send the patient to a not yet existing fall prevention facility, which is then done by geriatrician, a neurologist, and then physio and occupational therapist. And I think you have, so I always wanted to come and visit you, and probably there are a couple of reasons now to see this TBI outpatient clinic that you have, and you have talked about it on the ENO conference. So basically, that's something you already do, not specifically for TBI, for fall prevention, but you have a team that is not only based on neurosurgeons, but I think you have neurologists there, right? And I mean, this is something that we can steer patients into or towards, but we cannot do. But we are the ones. If we don't do it, nobody will do it. That's the problem, because we're the ones seeing them, and we try to get them out of our hospital as soon as possible with no, the least we have to do, like very easy decision. Okay, there's some mild TBI, but complicated by some blood. Okay, observation for a couple of hours, maybe a re-CCT, and then hopefully we can find a way to get the patient back to wherever he came from, or we have to organize some interims kind of care, but never do we do any let's say preventive measures. And probably we can't, but you should at least assess the risk. And I think the risk for many of those people is really high. And then have this kind of facility that you already have, but then specifically for prevention, etc. So I think I told you about this before. So now that I work in this trauma hospital, you can see how differently this goes. If you have a patient who is under this very special trauma insurance, he gets a clear pathway with a warden who will, reach out to him, who will guide him through various processes of rehabilitation and stay in touch with the patient for a longer period of time. And those patients, unfortunately, it's not old patients, but working patients. So it's not the group that I'm currently focusing on, but those patients, they get a lot of not very sex up to date, not very specific care, I would say, but they have somebody who looks after them and at least provides the things that are already somehow available in terms of rehabilitation and prevention. Nothing really new or fancy, but I mean the basics. But already having this person who looks for the patients and reaches out to them, and they have to come back to many times to get reassessed, etc. This already helps. So if you could have this for at least the older patients at a higher risk, would be very good, I think. But it would still be a lot of patients, obviously, that we would have to.
Thanks.
There are some comments in the Yeah, it's about the e-scooter that they have some issues as well in Hungary, and they're performing research. Yeah, Mohammed Al-Smadi, we look forward for your presenting your results in coming meetings. There is an increasing number of TBI due to blunt assaults and also gunshot wounds in the epidemiology, but there is less new info about the pathophysiology regarding these mechanisms in the literature. It was first in the military. Yeah, the civilian data are not as many, but we had the last EANS meeting in Vienna. We had a session about word TBI, and we had our colleagues from Ukraine who presented very nice data from military experience from this type of injury with penetrating head injury. And there are some civilian results from South Africa. We did some from Sweden, gang-related, and there are some few studies from United States as well.
I think aren't the penetrating TBI guidelines updated or have been updated or currently updated? So this would something you could go to get some new data, evidence, or recommendations, I think.
Yeah, it's on the Brain Trauma Foundation's website, and I think it will be published in December in GNS. Yes, correct. So it's 1822. Should be. So I don't see any more questions. Do you think we should summarize?
Sure. It's a nice time for summarizing, yes.
I think we had an excellent overview, and I really enjoyed your overview regarding the mechanism of the biomechanism of TBI, how it started. And I think one of the successes with Generelli's model was that it was a primate model. What do you think, Bart? Because it's really difficult with these rodent models, for example, to simulate and to understand the biomechanics of TBI.
Oh, well, certainly. So with a rodent, you cannot do that type of research, and in other words, you cannot replicate the exact mechanical pathogenesis of TBI as it is in humans, because they have such a small brain mass, and you would need, I don't know what kind of a machine to have that rotational acceleration. We tried in pigs, and it's already very difficult. And so what Tom generally did in his primates was actually groundbreaking research, and it let us understand so many things. But ethically here, and I would not, it's not just because society wouldn't accept it anymore, I would not accept it myself either, to do research for that type of research on primates. I don't think you can justify that anymore.
Yeah.
Bart, I want to comment again, because I think it's easy to forget if you, I mean, for me, I don't know, in my age, you start this neurotrauma, research, and you try to have interest in this topic, and then you forget to think about how many years of research have already been gone into this and put into this, how many decades, and how everything we know right now, we take it for granted, is somehow based on some experiments, some studies done. So this is really impressive. But
thank you so much, guys. And I think your room is not available anymore, Bart.
Yeah, we have to.
My boss just stumbled in here
to go home.
Talk to me. Okay.
Thank you, everyone, and thank you, Bart.
Thank you.
For very nice
Elham, Bart. Thank you, Elham.
Have a nice evening.
Excellent.
Bye, everyone.
Bye.
Thank you. Bye, Elham and Alex. Bye-bye.
Bye-bye.